Please start. We are live.
Good evening, all distinguished delegates and eminent speaker today, Dr. and Professor S.N. Rautray sir. I am Satish Rama Joshilkar from Zydus Life Sciences, Zydus Medica team. Honored to welcome you all to the scientific platform called CLEARTalk. On behalf of Zydus Life Sciences, I would like to express my gratitude and most sincere thanks for your presence for the scientific webinar. Talking about a brief introduction about CLEARTalk is one more initiative from Zydus, which encompasses one more facet of Unite Against Dyslipidemia. As you know, in India, 1.24 crores Indian population is suffering from uncontrolled LDL cholesterol. 7 out of 10 patients are having uncontrolled LDL cholesterol, which increases cardiovascular risks. And for that, recent development in the field of dyslipidemia management brings you bempedoic acid as an add-on choice for LDL cholesterol management. Hence, this session of CLEARTalk is focused on most recent development, which is on bempedoic acid. We witnessed late-breaking clear outcomes trials in ACC 2023. The program is based on objective of increasing awareness about usage of bempedoic acid for all practicing physicians and general practitioners. Is basically to upgrade the knowledge of late-breaking CVOT trial and management of LDL cholesterol and dyslipidemia. Well, to take this program ahead, I would like to welcome our today's eminent speaker for today's program. I would like to share a screen, a small brief introduction about Professor and Dr. S.N. Rautray sir. He is consultant cardiologist, professor and HOD of Cardiology Department, SCB Medical College and Hospitals, Cuttack. This is just a brief introduction. He is more experience and expertise in the field of dyslipidemia management, and we are eagerly waiting for your brief about how to manage LDL cholesterol. And the topic for today's presentation is bempedoic acid and ACL inhibiting regimen. So bempedoic acid through the lenses of clear outcomes trial, we are going to discuss with Dr. Professor S.N. Rautray sir. So without wasting much of our time, I would like to hand over the session to Professor Dr. S.N. Rautray sir. Thank you.
Thank you. Good evening, everybody. This evening, we are going to discuss one of the important trial in the field of management of lipid, particularly LDL cholesterol, the CLEAR outcome trial. As we all know, regarding this atherogenesis and a role of LDL cholesterol and the role of anti-lipid management. My slides are visible?
Yes, sir.
Yes. This exactly the bempedoic acid through the lenses of CLEAR outcome trial. For last 1 year or so, we are in many forums, we are discussing about the bempedoic acid. Why? Why? It is because it has been seen in spite of adequate dosage of statin, which is the standard of therapy of lipid lowering agent in high risk patients and in ASCVD, the target is not reached. We still need addition of other medications. And before bempedoic acid, we had in our hand ezetimibe, PCSK9 inhibitors. Now bempedoic acid and inclisiran, they have come up, and last 1 year there are several trials, particularly their CLEAR Harmony, all these trials they have come up, they have shown the usefulness of bempedoic acid. And SCC, AHA, they have also shown this ADA, they have also shown the bempedoic acid is helpful in management of dyslipidemia. But till now, the outcome trials are not there. And this is a first trial, which is outcome trial, the CVOT trial. What do we mean by this? and what it all mean, that will go through this presentation. If you see here, 1 millimole per liter reduction in LDL gives more CV reduction, CV risk reduction according to the number of years in trials and comorbid conditions as well. What do you mean by this? If you reduce the LDL cholesterol by 1 millimole per liter, almost 23% reduction in CV risk that occurs. But this varies from year to year. If this continue for 1 year, the reduction is about 11%, varies from 4 to 8%. If this medication continues and the reduction on the LDL cholesterol continue for more 2 years, it is around 24% reduction in the risk. In 3 to 5 or 33%, more than 6 or 36%. As the age advances, as the duration of treatment increases, as the LDL remains low for a longer period, the reduction of risk becomes more. And this is what this risk of non-fatal myocardial infarction, CHD death, and stroke has been shown here according to the LDL cholesterol or as per millimole per liter. Here is CBD plot: diabetes mellitus, cardiovascular disease, metabolic syndrome, and impaired fasting blood glucose. And if you see this, all these conditions, if there is reduction, this lipid, LDL level is directly responsible, directly related to the risk. So the management of dyslipidemia, particularly high on priority and statin, are first-line therapy agents. As we all know, the management of dyslipidemia just twist around the LDL cholesterol and the treatment is statin. There are so many non-statins have come up, but however, the statins have clearly shown the benefit as regards the outcomes, as regards the death reduction, as regards the reduction in cardiovascular mortality, cardiovascular morbidity, particularly see a non-fatal stroke, non-fatal MI, all these things. So the priority of statin at the first line of therapy. You see here, there are two concerns. Concern one, do all statins users achieve LDL cholesterol goal as per the guideline recommendations? A big no. That will come across in a further presentation. So in spite of giving the high intensity statin, all are not achieving the target level. And how to achieve this LDL cholesterol target after maximally tolerated dose of statin? After giving maximally tolerated dose of statin, still patients are there where this LDL target is not reached. So then comes the role of other agents which are available now, like ezetimibe, PCSK9 inhibitors, and bempedoic acid. Now, what the present trials say about this, we'll see. So let us see the first concern. What is the reduction of LDL goal with the guideline management of lipid treatment? So you see here, this LDL cholesterol, if you reduce the LDL cholesterol for a longer period, so definitely the benefit remains for a longer period. So you have to reduce the cholesterol to the target lowest possible and longer period to get the maximum benefit. These are the different trials with ezetimibe, fibrates, and niacin, and 25 trials of statins, bile acid sequestrants, ileal bypass, PCSK9 inhibitors. All trials are there. All have shown the reduction, relative risk reduction per 1 millimole per liter of reduction of LDL cholesterol translate to 23% relative risk reduction of cardiovascular events. This is the LDL target. You see LDL target, what it was there in ESC 2016 and how it is now in ES after ESC 2019. So these are the different risk category, CBD risk category. Low risk, moderate risk, high risk, or very high risk. And according to LDL cholesterol target, according to ESC 2016, and this is like this, and ESC 2019 that we'll see now, for all low risk patients, the LDL cholesterol target should be less than 115 milligram per DL. In moderate risk, it should be less than 100 milligram per DL. And high risk, it should be less than 70, and very high risk, it should be less than 55 milligram per DL. Now the Lipid Association of India, they have gone further. They have gone Further reduction, the same, very high risk less than 50 and very high risk even the category A and B. Likewise, you can go further down as per this requirement. So as the CV risk increases, the need to reduce the cholesterol becomes more. The more you have to come to the target, you need a lower level of LDL cholesterol. So all these things, the target is guided by the risk. How much risk is there? According to the target, it is varied. So based on the revised ESC 2019 guidelines, how many patients do have controlled LDL cholesterol? There is one large study, the Da Vinci study, that showed the light to this European Union-wide cross-sectional observational study on lipid modifying therapy used in secondary and primary care, the Da Vinci study. We see here is a cross-sectional observational study of patients prescribed lipid-lowering drugs for primary or secondary prevention. 18 countries of Europe were involved in this trial. The total number of patients were 5,888. For primary prevention, it was 3,000. For secondary prevention, 2,888 patients. What is the objective? To evaluate the impact of ESC 2019 dyslipidemia management guideline on LDL cholesterol goal achievement. So according to this guideline, how many percentage of patients achieve the target? What the Da Vinci study shows. If you see here, this Da Vinci overall patients, they were seen according to the proportion of patients receiving lipid lowering therapy. So the proportion of patients receiving lipid lowering therapy. If you see here, 27.6% are eligible for receive high intensity statin. High intensity statin. So this here, according to 2016 guideline and 2019 guideline, what is the target reached? In this study, it was seen 30% of the patients receiving high intensity statin achieved the lipid goal. Only 30% of the patients receiving the high intensity statin, they receive the lipid goal, that is 30%. If you go by the criteria of lipid target according to 2019. So if you go by 2016, it was a little higher because now the level has become lower, this achieving target has become low. Likewise, if you see here, the other category of patients like low intensity and moderate intensity statin, they have also achieving the target is also low. But when we are concerning and concentrating in the high intensity statin group, they are only achieving 30% achieve the target according to 2019 guidelines. If you see here, again, this is very high risk patients, those who belong to the very high risk patients. These are the lipid lowering, the proportion of patients lipid lowering therapy. You see, 37.5% of eligible patients are receiving high intensity statin. These are very high risk patients, they need very high intensity statin. It was found only 37.5% are receiving high intensity statin. And out of that, only 22% are to the target, that is less than 55 LDL cholesterol, less than 55 milligram per DL. So only 22% achieve lipid goal with high intensity statin in high risk category. So this target, there is a gap. That is gap means treatment gap. All the patients, those who need high intensity statin, they are not taking high intensity statin. And in those who are taking high intensity statin, in them also, some substantial number of patients are not reaching the target. That is very important. So there's a need for a second agent, second medication to show the benefit of lipid lowering therapy there. So there are, as we are discussing the other one, what are the other medications that we come for? One is ezetimibe, PCSK9 inhibitors, inclisiran, they have shown, and this bempedoic acid. There are certain small trials in bempedoic acid. They have shown that useful in patients, those who are unable to take or intolerant to statins, and in patients where this target is not achieved. Actually, FDA has approved this medication of this agent. ACCA says when patient is not achieving the target in spite of highest tolerated statin dose, and in patients of statin intolerance, we can give bempedoic acid. Bempedoic acid is usually given in a dose of 180 milligram daily, and with or without. If you see here, all of us have discussed regarding the bempedoic acid. This is a novel molecule, the novel mechanism of action. It acts at ATP citrate lyase. And if you see here, our statin act at HMG-CoA reductase inhibitor. This agent bempedoic acid acts higher, that is prior to this. In the same way, pathway, it acts prior to this. Here, bempedoic acid just converted to active drug bempedoic-CoA that actually inhibits this ACL, that is the ATP citrate lyase enzymes. By that, it reduce the cholesterol synthesis, upgrade LDL receptors of regulation, reduce the LDL cholesterol. At the same time, it also hampers this clearance of uric acid. There is a chance of rise of uric acid, and good thing is that if you see here, this half-life of bempedoic acid is around 21 hours, and eliminated 70% excreted to total through the kidney, 5% kisses and 2% unchanged drug through the kidney. This is one of the very important table which shows where we concern, where we should monitor, where we should discontinue the treatment of bempedoic acid. The concerns means if there is renal impairment and hepatic impairment, if the mild impairment of kidney or liver, there is no concern. However, the trials are not there in severe impairment. If you see here renal impairment, no dosage adjustment is required. Not studied is end-stage renal failure. So less than 30 eGFR, it is not studied. So end-stage renal failure, we are not going to give this, but in other situations, no need of drug adjustment. Dosage adjustment. Similarly, in hepatic impairment, not studied in patients with severe hepatic impairment. Here we are not going to give, but in milder form, no dosage adjustment is required. And all patients here, we will pursue where to monitor, assess serum uric acid when clinically indicated. Usually, it is better to start assess the uric acid at the beginning of the therapy. We should know which patients, and the patient has got a history of uricemia, hyperuricemia, and gout. We have to be more careful. And prior history of gout. If there is prior history of gout, there is increased vigilance for hyperuricemia and gout, because likely that this may precipitate hyperuricemia and gout. And monitor if the patient is more than 60 years, taking corticosteroid or fluoroquinolone with renal impairment and history of tendon rupture. One or potential for tendon rupture, and advise patient to rest at first sign of tendinitis or tendon rupture. If the patient here, this side, if you see from going to down up, breastfeeding, there is no recommendation during the breastfeeding, bempedoic, there is no study. Pregnancy, no study. So discontinue bempedoic acid if patient is taking, or do not give bempedoic acid. The benefit of therapy outweighs the potential risk to the fetus. When the patient taking simvastatin more than 20 or pravastatin more than 40, it cannot be added. Again, in patients above 60 years of age, taking corticosteroids or fluoroquinolone with renal failure, with a history of tendon rupture, definitely you are not going to give bempedoic acid. If the patient is taking bempedoic acid, it has to be discontinued. Discontinue if tendon rupture occurs. Consider discontinuing if joint pain, swelling, or joint inflammation occurs in any patients on bempedoic acid therapy. So if you see it here, this is the trial which we are going to discuss today, because this trial has shown the evidence that it reduces the cardiovascular endpoint, CV endpoint, the CVOT trial. This is clear outcome trial, the cholesterol lowering via bempedoic acid in ACL inhibiting regimen. So ATF citrate lyase inhibiting regimen. This came as a late-breaking clinical trial, ACC 2023, and recently it has been published in NEJM, New England Journal of Medicine. If you see here, what is the criteria for inclusion? This is a global CVOT study of bempedoic acid in statin intolerant patients with elevated cholesterol. These patients, those who did not tolerate statin, they statin intolerant, where there is, when this statin intolerant, where it is the patient are not willing to take statin, these patients are included. Their primary and secondary prevention patients with elevated LDL cholesterol and statin intolerance. If you see statin in their screening in the visit, in the past visit, they screen for statin intolerance. And then in the second visit, 4-week run-in period treatment with single blind placebo. And after that, in third visit, the day one, this is visit for therapy, where they are divided into two groups. One group take bempedoic acid 180 milligram per day, and other group take placebo. So nearly 7,000 patients in each group, and they visit in the next 1 month, 3 months, and 6 months, alternating phone contact or clinic visit every 3 months thereafter. So first, then 1 month, then 3 months, 6 months, then alternately either they come to the clinic or phone contact, they are followed up. And in this study, the median follow-up was 40.6 months. And the primary endpoints were four component endpoints and 3 component endpoints. The effect of bempedoic acid blood placebo and 4-point MES. What are these 4-point MES? The cardiovascular death, non-fatal MI, non-fatal stroke, or coronary revascularization. These are the 4 points. CV death, non-fatal MI, non-fatal stroke, or coronary revascularization. Here, this they targeted the minimum 1620 events of primary component events, then study to be targeted. Here, study completion 1620 primary 4-point MES, 4-component MES, at least 810 3-component MES, and treatment for at least 2 years. Here, 13,970 patients were included. The phase 3 clinical trial median follow-up was 40.6 months. This is the patient demographic criteria. If you see here, their age and sex matched group, and average age of the patients were about 65 in both the group. Body mass was around 30 in both the group. LDL cholesterol was around 140 in both the groups. If you see eGFR in similar in different category, primary prevention, about 30% of the patients were for primary prevention, about 70% of the patients were for secondary prevention. Out of secondary prevention, mostly there are coronary disease, peripheral arterial disease, and cerebrovascular disease. One thing is that in this study population, diabetes was very prevalent. Diabetic patients were 45 to 46% bempedoic and placebo arm, and abnormal impaired glucose tolerance is almost 19.4 and 19.6%. Statin was used here and the ezetimibe in it. So what is the result came? This outcome 4-point MES, relative risk reduction of 13%, 3-point MES, relative risk reduction of 15%, fatal or non-fatal MI. This gives the maximum reduction of relative risk reduction of 23%, coronary revascularization was 19%. P-value is less than 0.05. Here I want to emphasize one thing. What in earlier studies we have seen, bempedoic reduce the LDL cholesterol if used alone around 20 to 25%. If we used over and above statin, is reduced further 15 to 20%. Here in this study, the patients mostly they were not taking statins. They were statin intolerant or they are not willing to statin. In those patients, bempedoic acid was given, and average reduction is around 21% in LDL cholesterol. If you see here in the first one, this is cumulative incidence of 4-point MES reduction. This is the hazard ratio is 0.87, 13-point relative risk reduction, p-value 0.004. And 3-component MES, here p-value is 0.007 and 15% relative risk reduction. And the fatal and non-fatal MI, here we get the maximum benefit, hazard ratio is 0.77 and about 23% relative risk reduction, p-value 0.02. and coronary revascularization around 19% relative risk reduction. So in this study, if you see, these patients, those were included, they were statin intolerant. Bempedoic acid was used, and it has been found about 10 to 15% of patients treated with statin, they do not tolerate statin to prevent patients from achieving LDL goal and cardiovascular benefits. And bempedoic acid was used in 180 milligrams per day, and cardiovascular outcome here in this study approved for lipid lowering agent was assessed. What it has found, these are primary and secondary key endpoints as we discussed. The primary key endpoints are 4-point MACE. 4-point MACE are cardiovascular death, non-fatal MI, non-fatal stroke, and coronary revascularization. And the secondary endpoints by hierarchical testing of the key secondary endpoints. If you see here, 3-component MACE, that's the MI, stroke, or CP death. Here, coronary revascularization is not there. Other is fatal and non-fatal MI, coronary revascularization, fatal and CP death, and all such mortality. These are taken separately as separate parameters, and accordingly, patient was assessed. So, what it was found, among the statin intolerant patients, treatment of the bempedoic acid was associated with a lower risk of all these things: 4-component MACE, 3-component MACE, MI, and coronary revascularization. As we discussed earlier, 4-point MACE was reduced by 13%, 3-point MACE by 15%, MI by 23%, and coronary revascularization by 19%. So this is actually another study which shows this evidences shows the reduction of CV events, the non-statin, the reducing the CV events. That is the bempedoic acid in this trial, this clear outcome trial has shown another evidence-based non-statin molecule reducing the CV events. So, another thing, it has been seen this bempedoic acid also has pleiotropic effect. It reduces the HSCRP. HSCRP in this trial, it was seen 21.7% reduction of LDL cholesterol and 22.2% reduction in HSCRP. And over the months, 6 months, 12 months, till end of trial, the benefit remained persistent. So this is a trial you can see where this follow-up was about, median follow-up was 40.6 months. So even in the long follow-up, bempedoic acid has been found to be beneficial, reducing the cardiovascular endpoints in patients who are non-intolerant to statin, they are statin intolerant patients. If you see here, there is safety analysis. This is, you see, bempedoic acid in a placebo arm. There's not much of a difference, except these are the fair differences. I am showing it. Renal impairment, 8.6% in placebo arm, 11.5% in bempedoic acid. Again, hyperuricemia, 5.6 and 10.9. So chances of hyperuricemia is more with bempedoic acid. If the patient is having gout, chances of precipitation of the gout is more if the patient is taking bempedoic acid. And change from baseline uric acid at 6 months from 0.07 is there. So change in uric acid, chances of gout, chances of tendon rupture are more in patients with bempedoic acid, and slight increase in the renal impairment. It has been found in the analysis for the safety analysis. So we can say this is the first trial on bempedoic acid. It has shown the reduction of LDL cholesterol by about 21.6%, reduction of HSCRP by 22%, and reduction in all 4-point MACE is reduced. And cardiovascular death by 13%, cardiovascular in this non-fatal MI by 15%, and reduction in this revascularization is about 19%. All these things are reduced. If you see here, the bempedoic acid become the first ACL inhibitor and a first oral non-statin to demonstrate statistically significant reduction in MACE, 4-point MACE in patients who are at high risk of cardiovascular disease with documented statin intolerance and elevated LDL cholesterol. And here in this trial, both primary and secondary intervention were there, both in the primary and secondary intervention group. It was found to be beneficial. According to this trial, the conclusion: bempedoic acid, an effective alternative for statin intolerant patients. In this clear outcome study, it is found is well tolerated. Bempedoic acid was well tolerated in a mixed population of primary and secondary prevention patients unable or unwilling to take statins. So these are patients were either statin intolerant or they are not willing to take statins. And in these patients, it has been found to be safe and well tolerated. A reduction in LDL cholesterol and hsCRP. So bempedoic acid reduced the LDL cholesterol by 21.7% and reduced hsCRP by 22.2%. There is small increases in the incidence of gout and cholelithiasis. In the safety analysis, it was seen a slight increase in the incidence of hyperuricemia, the incidence of gout, and incidence of cholelithiasis. You see the primary and secondary endpoints. The primary endpoint, that is 4-point MACE composite MS, 4-point MACE was reduced by 13%. 3-point MACE composite of 3-point MACE reduced by 15%. Myocardial infarction was reduced by 23%, and coronary revascularization was reduced by 19%. So there is substantial risk reduction, which is statistically significant as compared to the placebo in this study. So bempedoic acid is an effective approach to reduce major cardiovascular event in statin intolerant patients. So now we have got the evidence in favor of another molecule, which is non-statin, which is shown to be beneficial as regards reducing the primary and secondary endpoints, 4-point MACE, 3-point MACE, myocardial infarction, and coronary vascularization. Now to the clinicians, how to get the benefit of reducing this LDL cholesterol target in addition to patients with statin therapy where the target is not achieved, or in patients where they are statin intolerant. So this is a study which has shown in patients who are statin intolerant or patients unwilling to take statins, and by adding bempedoic acid compared to placebo, there is definite risk reduction as regards primary and secondary endpoints. And the evidences are in favor of use of statins. And evidences are there in favor in use of bempedoic acid when patient is statin intolerant, according to this study. Thank you. I think we'll have more of interaction, more of discussion on this new trial which has come up.
Thank you so much, sir, clearing our doubts with this clear talk on bempedoic acid and the clear outcome trial. Moving towards the most important interactive session, the questions which I have received from the audience. So one such question which I have received is of like you said initially that in 2019 ESC guidelines there is a stricter reduction in LDL cholesterol which is being projected. So there is one question regarding this. Many patients have uncontrolled LDL cholesterol, but they don't have any complications. So should I increase the dose of statin or to add bempedoic acid or ezetimibe?
So you mean to say the patient do not have other complications, other cardiovascular disease. However, this LDL cholesterol is high.
Yes.
The question arises, we'll have to look for the ASCVD risk. We'll have to risk calculate such patients. According to risk calculator, what is the chances, if there is associated other comorbidity. So which category the patient belongs? Patient belong to low category, ASCVD low risk, moderate risk, high risk, or very high risk. Accordingly, the target will vary. So, if depending upon the LDL cholesterol, depending upon the associated disease and associated conditions, the risk varies. So, if according to the risk category, patient is not achieving the target. Say, for example, low risk, it is less than LDL less than 115. If a moderate risk, less than 100. If the high risk, less than 70. Very high risk, less than 55, according to ESC goal. So if it is not achieved with this risk category patients, definitely we are going to add other agents. Till now, what was there in the guideline, because regarding the definite use and all these things about bempedoic acid has not come up. Till now, what was there, if it is not controlled, we can go and add ezetimibe. If it is still not controlled, we can go for PCSK9 inhibitors or a combination of both. Now the trial has come, now the evidence has come, that definitely reduction of CV events. Now the guideline may include bempedoic acid in this scenario where this target is not achieved with the statin. We can go for a bempedoic acid, and bempedoic acid, if you see like ezetimibe, it's the oral agent, whereas the PCSK9 inhibitor is injectable, is a costly, and it has to be given by injection. So this is a oral medication. This can be taken with or without food. Definitely benefit is there. And many of the PSCC, HSA, Americans, they're afraid of taking statins. That is again another point. Unwilling to take statin is a point in USA at present. So in such situation, definitely bempedoic acid is going to play a major role.
Thank you, sir, throwing light on this question, and hope the question has been answered very well. So second question, which is there in chat box, which is, I have many patients with type 2 diabetes mellitus and hypertension. So what LDL target should I keep for these patients?
Yes. If there is established ASCVD, say that is, we have found out there is a patient is having MI, patient has undergone CAVG, patient undergone PCI, angio has been done. There is if there is myocardial infarction, they belong to very high risk category. There is very high risk of ASCVD, and diabetes itself put them into high risk category. Definitely in such patients, we can use statin, we can use bempedoic acid, but if even ADA has mentioned this role of bempedoic acid in the management of diabetic dyslipidemia. Already there, one step ahead, they have mentioned the role of bempedoic acid in diabetic dyslipidemia. So in such patients, they usually diabetics, they belong to high risk category. In such patients, definitely till now, as per the guideline, statin is the number one drug. And now the evidence has come. And in this study, if you see clear outcome study, 50%, 45% of patients were diabetic, and about 20% were having metabolic syndrome or impaired glucose tolerance. So almost 65% of patients were diabetic. In this diabetic subset, this trial has shown the benefit with bempedoic acid. If you see the extent of benefit, if you ask me, you see the extent of reduction without addition of statin is 21.7% in this study, and this benefit is according to that. If the patients say having very high risk and your LDL cholesterol is high, maybe only bempedoic acid may be inadequate to bring down the LDL cholesterol to the target. In such situation, is a very good drug in addition to add to our statin to bring down the LDL cholesterol to the target.
Thank you so much, sir. This arises a next question in the link linking with the previous question was, as per clinical trial data, is it more beneficial to use bempedoic acid in pre-diabetes patients to delay new onset of diabetes mellitus, or how much bempedoic acid is safe to use for longer duration, and whether it is benefiting diabetic mellitus patients?
benefit in pre-diabetic patient, this is again a $1 million question because there are several drugs, several trials. There, even all these pre-diabetic patients, they are at high risk of ASCVD. All of us know. But at the same time, several drugs have been tried in the pre-diabetics, but the definite guideline, definite evidence bases are not there with most of the agents. If you see, metformin has been found to be beneficial in some studies, statins, etc. has been found to be beneficial. In this study, we have seen this patients, those who are having impaired glucose tolerance, in such patients, this bempedoic acid has been found to be beneficial, but this trial is not targeted to this population. This targeted to population there high risk of ASCVD, primary prevention or secondary prevention. Already with established ASCVD, there is secondary prevention, 70% for secondary prevention, 30% primary prevention. In such patients, it has been found to be beneficial. But to say definitely in the scientific era, in the age of science, we cannot say, because unless the trial is targeted to that, we cannot say definitely. But the evidences are there, it will be beneficial in such subset of patients.
Thank you so much, sir. Next question is it appropriate to keep LDL cholesterol below 40 milligram per deciliter as per guideline recommendations, or can it lead to neurological complication? This is one question which...
Yes. This question arises because when the target becomes for LDL, lower the better, longer the better. So you have to lower the LDL cholesterol for a longer period. So this question, this is a moving target, I will say, because till now, 2019, ESC has given this target. Lipid Association of India, now it has gone further. In high risk subset, very high risk, then less than 50. And again, they categorize A and B, the recurrence of microinfarction, recurrence of ASCVD, where you have to go up to 30. So even if you go up to 30, it isn't found to be safe. It has to be found to be associated not much of side effects. There is substantial, fear or doubt regarding reducing this LDL cholesterol. There may be some neurological complications, but trials are there, evidence are there. They're not having no definite neurological complications. There may be stray case reports, but evidences in general, according to science, is not there. You can reduce below 40, up to 30, we can reduce. It is in found our aborigines, they were having very low LDL cholesterol, they're around 30 to 40. So below 40 is quite safe. But at the same time, each patient has to be taken separately. In one particular patient may be different. When we are clinician, we are giving the drug, we must keep an eye on such patients. Those who are having very low cholesterol level, we'll have to look for all these complications. If there is any doubt, then we can think of. But evidences, guidelines are not against going so down. That means you can safely go down, but we should be careful in particular patients. We'll have to care.
Thank you so much, sir. The last question probably of this, which I have received on screen, is what percent of statin intolerance do you observe in routine practice? Can bempedoic acid be a drug of choice for those patients?
Yeah, this is a very important question. If you see, maybe last ICC, I was giving a talk on statin intolerance. So analyzing the studies, main part statin intolerance, of course, is statin related muscle symptoms, mostly muscular pain, myositis, or rise in enzymes, CK, or sometimes liver enzymes. But if you see, in general, different studies present differently. There are studies where it is up to 15%, but most of the studies vary from 5 to 10 to 12% of patients may have statin intolerance. And in such situation, most symptoms are muscle-related symptoms. if you look at the liver toxicity or redox or this rise in SGOT, SGPT, that become very less than 1% of the patients, sometimes 0.1 to 1% of patients do have such symptoms. But muscle-related symptoms do occur with hydrostatin, but we should be careful. We should be aware. Many times patients come, they complain that we are having myalgia, we are having backache, we are having muscle pain. Sometimes if we are busy, we may ignore. But if the patient is taking statin, patient is hydrostatin, we should keep cognizance of this. We should investigate and we should find out. So many times it is many times it is ignored or not properly diagnosed. But if you take higher dose of statin, chances what I told maybe around 5%, 5 to 10%, but in other patients it may be lower. But still then, if the patient is having some symptoms, we must give it importance, we must investigate. And in such situation, till now, regarding the use of bempedoic acid, what we have seen, this trial has come, where the patient, these patients all 13,970 patients, most of these patients were statin intolerant or they were reluctant to statin, they are unable to take statin because of statin intolerance. So in large population of patients, bempedoic acid has been found to be beneficial as regards reducing the LDL cholesterol, reducing the HSCRP, and reducing the CV events, reducing the MI, 4-point MACE, 3-point MACE, all these things have been reduced. So this has come a drug, in particularly this subset of patients, the patients who do not tolerate statin, bempedoic acid remain a real alternative to treatment in this subset of patients. Because earlier when bempedoic acid was not there, either we are going to ezetimibe or PCSK9 inhibitors. Sometimes we were using the alternate day statin, changing the statin to other statin like this. Now we have a drug with this setup we can use easily. The evidences are there in favor of use.
Thank you so much, sir. Thank you. This is such an insightful and your in clinic expertise, which definitely will help healthcare practitioners across India. And definitely this would be a point of discussion to start bempedoic acid as an add-on choice to statin treatment. And sure that clear outcome trials and the CLEARTalk which you have given has cleared all our doubts on bempedoic acid, and definitely this will help all of us. Any final remarks, any final talk before we say vote of thanks on bempedoic acid?
I'll say one thing. For last 1 year, we are discussing bempedoic acid. All the time we are asking, what are the outcome trials? Where is the outcome trials? Because we clinicians always, scientist is different, researcher is different. Clinician usually use if there is outcome trials. Now the outcome trial has come where it has shown this benefit of bempedoic acid, particularly in the subset of patients, those who are statin intolerant. At the same time, earlier studies have shown this reducing the LDL further if you add to statins where the target is not achieved. So now we have got an agent other than statin, which reduces the CV endpoints, particularly fatal, non-fatal MI, revascularization, CV death, and all 4-point MACE. So this time has come. We can use our knowledge, use this beneficial agent in the patients where it is needed. Thank you.
Thank you so much, sir. I would like to hand over session to Mr. Sambit, who is heading the region. Sambit, the final vote of thanks from your side.
Sambit was unmute.
Not audible, Sambita. So Okay, I think there is some technical
Yeah,
issue Samvida is facing. Thank you, sir. Thank you so much for being a part of this Clear Talk and such a wonderful being such a wonderful faculty for Clear Talk. And I'm sure the knowledge which we have gathered today with you, the discussion with your clinical expertise, would definitely help many physicians across India. And I would like to give special thanks from Zydus for your presence here. Thank you so much and have a nice evening, sir. And
Thank you.
I thank all the participants for being a patient listener, and thank you everyone. Have a nice day. Good night. Bye bye.